Welcome to CleanMedKE, where we make clinical medicine and surgery clear, structured, and clinical. Today, we're diving into the command center of the human body, the Hypothalamic-Pituitary Axis. Before we begin, note this content is for educational purposes only and does not constitute medical advice. The hypothalamus acts as a bridge between your nervous and endocrine systems. It sits just below the thalamus and funnels complex brain signals down through a physical tether called the infundibulum, or pituitary stalk, to the pituitary gland. This pea-sized master gland rests securely within a bony cavity known as the Sella Turcica, or the Turkish saddle. To understand how this axis works, we have to look at where it comes from. The pituitary is actually two very different tissues joined together. The anterior pituitary, or adenohypophysis, grows upward from Rathke's pouch in the mouth, making it glandular epithelial tissue. On the other hand, the posterior pituitary, or neurohypophysis, is a downward growth from the hypothalamus itself, meaning it is neural secretory tissue made of unmyelinated axons and supporting pituocytes. Because they have different origins, they talk to the hypothalamus differently. The anterior portion uses the Hypophyseal Portal System, a vascular connection where releasing hormones travel through blood vessels. The posterior portion, however, uses the Hypothalamic-Hypophyseal Tract. This is a direct neural connection, where axons from the hypothalamus travel down the stalk to terminate in the posterior pituitary. Think of this system like a corporate ladder. The hypothalamus is the CEO, providing strategic control by releasing tiny amounts of hormones. The anterior pituitary is the general manager, receiving those orders and secreting tropic hormones to the staff. The staff, the thyroid, adrenal cortex, and gonads, execute the orders by releasing systemic hormones. Interestingly, there are independent contractors, like the parathyroid and pancreas, that don't report to the pituitary at all. They respond directly to things like calcium and glucose levels. To remember what the general manager produces, use the mnemonic flat peg. The basophils are responsible for the tropic hormones, FSH, LH, ACTH, and TSH. These hormones do not act on tissues directly. Instead, they travel through the bloodstream to target other glands, such as the thyroid, adrenal cortex, and gonads, to trigger the release of systemic hormones. In contrast, the acidophils produce the direct hormones: prolactin for milk production, endorphins for pain regulation, and growth hormone for bone and muscle development. These differ from the tropic hormones because they bypass other glands and act directly on their target tissues to produce a physiological effect. Unlike the anterior, the posterior pituitary doesn't actually synthesize hormones. It's a storage facility. The supraoptic nucleus makes ADH to regulate water reabsorption in the kidneys, while the paraventricular nucleus makes oxytocin for labor and social bonding. These hormones travel down axons and are stored in distended nerve terminals called herring bodies until they are needed. Regulation happens through feedback loops. Most of the body operates on negative feedback, a homeostatic stop signal, where the final product inhibits its own production to keep things stable. For instance, high T3 or T4 in the blood signals the hypothalamus to stop TRH and pituitary to stop TSH. Occasionally, we see positive feedback, like an explosive amplification. A great example is oxytocin during labor. More contractions trigger more oxytocin, which triggers even more contractions. The hypothalamus also controls our basic drives. The ventromedial nucleus is your satiety center, telling you to stop eating, while the lateral nucleus is the hunger center. We also have the suprachiasmatic nucleus, which is our biological clock, and the mammillary bodies, which are crucial for memory consolidation. In the clinic, we use these tiers to locate a problem. In primary failure, the target gland, like the thyroid, fails, so the pituitary screams with high TSH, but the thyroid can't answer. In secondary failure, the manager, pituitary, is asleep, so both TSH and T4 are low. Tertiary failure is a total systemic failure, starting at the top with the CEO, hypothalamus. When things go wrong structurally, the effects are dramatic. A ventromedial lesion destroys the satiety center, leading to severe obesity, while a lateral lesion destroys hunger, leading to anorexia. We also see adenomas, or tumors. A somatotroph adenoma causes gigantism, or acromegaly, due to excess growth hormone. One of the most common tumors is the prolactinoma. Prolactin is usually kept in check by dopamine. A tumor bypasses this, causing high prolactin, which shuts down the reproductive axis. In females, this presents as amenorrhea and inappropriate milk production. In males, it leads to impotence and gynecomastia. Remember the maxim: impotence in males is the neuroendocrine equivalent of amenorrhea in females. Treating these conditions requires mimicking nature. Pulsatile dosing mimics natural rhythmic spikes to stimulate a target. However, continuous dosing acts as a suppressor. A constant drip overwhelms the receptors and eventually shuts down the target organ. Management can be medical or surgical. For prolactinomas, we use dopamine agonists like bromocriptine to shrink the tumor by mimicking natural inhibition. If the tumor is too large or refractory, surgeons perform a transsphenoidal resection, accessing the pituitary through the nasal cavity to avoid opening the skull. That wraps up our clinical atlas of the hypothalamic-pituitary axis. If you found this clinical summary helpful, please like, share, and subscribe to CleanMedKE. Your support helps us bring you more structured, high-yield clinical medicine, physiology breakdowns, and pathology deep dives. Thanks for learning with us.